WHO projects count, and it is social problems related to health and medicine, or health and healthcare. So health is obviously has biological / medical components to it. Like, nobody's denying that, right? Obviously, there's a medical piece to health. However, what we are interested in as social scientists is more about the social construction of health, meaning how we as a society understand what health is, less about like disease, germ theory and stuff like that, right? So for example, the World Health Organization, the WHO, we're all familiar with them, way back in 1948, defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So as far back as 1948, health professionals around the world were acknowledging that health doesn't just mean not sick, right? It doesn't just mean the absence of disease. It actually is an affirmative situation where you are in a state of well-being physically, mentally, and socially. Does that make sense? Yeah. Despite this being around since as early as 1940, right, even today in 2021, many medical professionals focus on treating and curing diseases rather than on promoting the long-term well-being of their patients. Sometimes in slang you hear people talk about it's not health care, it's sick care, right? That you only get treatment when you're sick. There's not a lot of focusing on, overall wellness. Although, I think that might be changing a little bit. Anyway, this is in the medical community, right? There's an acknowledgement that it's not just the absence of disease and that social factors play a role in health. Sociologists who study health, like, for example, Dr. Kate Darling at UMA. Dr. Darling is one of the 3 sociology professors in our program. Dr. James Cook is the other. And Dr. Darling is a medical sociologist. Her degree is in the overlap of medical, healthcare and sociology. And she and other sociologists argue that how we think about health and illness are really socially constructed. For example, did you know that there is a theory out there that argues that racism, having racist attitudes and beliefs, is actually a form of mental illness? It's related to an obsessive compulsive disorder, I believe, where a person fixates on incorrect categories of, people and what to expect from them. I'm not a psychologist and I'm not a mental health specialist, so I don't know all the details of the argument. But the point is, right, something that's a very social behavior is in some circles being treated as an illness, right? Not just as somebody being a jerk or whatever. One thing we are certain of, both sociologists and medical professionals, is that our socioeconomic inequalities, like our social class differences, our race differences, our gender differences, are at the root of most health-related social problems. So, take the opioid epidemic, for example, right? And in particular, the overdose epidemic. That's a health-related social problem, and poverty and education and race are very strongly intertwined in the opioid epidemic, right? As factors in usage and in treatment and all those kinds of things. So one thing we can agree on as medical people and social scientists is there's an overlap here, right? So historically speaking, constructions of health have had these social connotations. For example, one of the earliest conceptions of illness was among the ancient Greeks, earliest recorded that we have access to. The ancient Greeks and Romans often saw people being ill as people being punished for being immoral, right? The gods were displeased by a person, and so they afflicted them with pox or with what ended up being cholera, but we didn't know that's what it was. Like that if you were ill, you were being punished for sinning, right? In fact, the early church, which of course is much later than the Greeks, but still, the early church saw leprosy, that particular disease, as being tied directly to sinful behavior, and that's why there's all this horrible treatment of lepers, putting them in leper colonies and not touching them, and right, it's not because it's a particularly communicable disease. It can be in certain circumstances, but you can't just get it from being around somebody. The reason they were so separated from society was because they were seen as socially unclean, right? Socially damaged goods. As medicine developed and separated itself from the church, it became less about morals, but still judgmental, right? And instead of being tied to sinfulness, disease started being seen as a product of people making unhealthy decisions, that you are doing something wrong and it's causing you to become sick, right? Well, what are the things that can lead people to be unhealthy? Being in poverty. Is that really a decision anybody makes? Living in filthy conditions, right? So, this is before modern sewage and clean water and our understandings of germs and stuff like that, right? So what were the things that were causing people to be sick? Being poor, being dirty, right? These aren't things that are like intentional decisions by people. They are social conditions, right? But we started attributing being poor and being dirty as being the result of an inferior moral character. Here, morals come back in yet again, right? So, for example, I mentioned cholera a minute ago. Cholera is a waterborne illness. It results in diarrhea and things like that, and people become dehydrated and die from it. It's
when you say cholera results in diarrhea, it might be helpful to explain we're not talking about diarrhea.
Correct, the kind that will kill you.
The violent, the uncontrolled,
The not polite description of what we're talking about. Yeah, this is a disease that drains all of the moisture from your body and you die of dehydration, right? It's a very bad thing. But it is spread, the bacteria, right, or germ, if you will, spread through the water. And so every time there's a cholera outbreak, let's say in a city like London, right, the cholera outbreaks tended to be focused in poorer neighborhoods, right? Well, they didn't realize it was because of the water yet, right? So what they thought is that poor people get cholera, not rich people, right? The fancy neighborhoods never had cholera because, by the way, it's because they all had their own individual water taps and whatever, right? Whereas in the poorer neighborhoods, there'd be like one tap in the middle of the town square or whatever, and everybody would share from there. But they saw the connection between rich and poor in cholera, but it didn't like dawn on. So then they were like, oh, it's the poor people that are getting sick because they're poor and they're inferior, right? When in reality it was just that they had to share their water because they were poor, whereas the rich people could have their own clean water. Does that make sense? So they're like mistaking, bigger social issues as failings of moral character. So eventually, we figured, some people figured that out, that it wasn't just poor people getting cholera, and we'll come back to that cholera epidemic in a few minutes. But even today, even in our modern medical system and our modern understanding of disease and all that, there are still many medical conditions that are associated with poverty, but that are treated as the fault of the afflicted. So, for example, lung cancer is an illness that is often treated as, well, you did something to get that, right? Like smoking, for example. Even though lung cancer rates are extremely high among people in poverty and not as high among the wealthy. Partially because they have access to preventive medicine, they have access to yearly physicals to catch things early on so that they don't metastasize and become more serious. right? But either way, lung cancer is associated with being poor more than it's associated with being just among smokers, I should say, right? Another example is obesity. So when it comes to like eating disorders and things like that, disorders like anorexia and bulimia tend to be associated with wealthy, middle class or upper middle class white women on average, but even men. But it is a disease of the rich or the middle class. It's seen as a mental illness, right, that deserves treatment and counseling and things like that, right? Obesity, on the other hand, is an eating disorder-ish associated with poverty, right? It is much more common among people in poverty because of poor access to nutrition and food deserts and stuff like that. Yet obesity is not treated as a mental illness or as something that requires counseling. It's seen as, you're lazy and you did this to yourself, right? So even though we've come a long way since the cholera epidemic or since the ancient Greeks, we're still treating some diseases as if it's the moral failing of certain people rather than tied to bigger social factors. Question or comment? Yeah.
Food desert?
I did say food desert. A new term for, okay. So, no, that's good. And I think I might mention it later. But a food desert is a region or space, geographical location where there is not easy, reliable access to nutritious food. So, a lot of inner cities, right? You can get plenty of fast food, but no organic grocery stores or no farm stands or whatever. So,
Thank you.
Yep. You get plenty of mayonnaise, but no vegetables or whatever,
Everything processed.
Exactly. Processed foods are easy to come by and they're cheap, right? Whereas organic, produce or farm-raised beef are way expensive.
We're actually seeing that locally.
Correct.
With the restaurants that serve the fresher food.
Having
Out of everything, like the Chipotle, the Panera, those. Whereas like your McDonald's, your Burger King, they're on.
they've stockpiled in the freezers for years or whatever. Yeah.
The fresh food places are getting hit rough.
Yeah. Although the ones that are locally sourced, they don't have supply chain issues. So there's it's like this weird dip in the, yes, that is true. And so oftentimes you see food deserts in rural areas or inner city areas, which are of course both linked to poverty, right? So, yep. Great question. So why does this matter, right? Like, okay, so yeah, we're blaming people, but is that really who cares, right? Well, how we understand the illness itself affects how we treat the illness, right? How we understand illness affects how we find an effective remedy. And so if we are focused on individualist causes, if we think it's your fault that you're obese, right, then we will come up with individualistic solutions. You should lose weight, right? And you know what? That is something that can help with obesity, right? Is someone working individually to lose weight. But obesity as a problem among Americans, which it is, right, is not going to be solved by a go work out kind of attitude, right? There's a bigger problem. Same with lung cancer or heart disease or any number, of STDs, right? If we only focus on individualistic causes, we will only come up with individualistic solutions. Whereas if society understands disease solely as the result of a biological cause, that if we just assume it's a germ and that's it, we may not see the need for a social response. Case in point, COVID-19, right? If we only think about COVID-19 as a germ, then we may not see the social factors that are related to the pandemic being ongoing and spreading and causing harm and death, right? It's more than just a germ. There are social behaviors, social responses that are and are not working, right? And so if we only think about it in biological terms, we may not see there are social things we can do.
There's somewhat of a motivating component to this too, that if we're thinking that it's your own fault, you get less motivated
To solve it?
to solve it.
Absolutely. Whereas if it's something that could happen to anybody or that society is causing and, I think by framing certain medical conditions as individual problems we are failing to care at a social level. Absolutely. I think about that too every time I see articles about like canceling student debt, and all the people in the comments are like, well, I paid off my debt, why can't they? And I'm always like, well, that's true and that's good for you, but like you're failing to see the bigger problem. Like, but yeah, if you're focusing on the morality of the people, right, or their choices, you may miss like the bigger issues that are causing these problems. And it's probably a mix of both individual choices and social factors. Like nobody's saying it can only be one. So ultimately, at the end of the day, hopefully, I've convinced you that social health issues in society are social issues in society, right? Excuse me. In order for there to be a collective response to health-related social problems, the public and the medical community must understand that health problems are social problems, and they affect all of society. And, I will say I don't want to say it's a positive outcome of the pandemic, because, it's not a great thing, but one silver lining of the pandemic is some of these features of the social health issues being social issues have been brought to light in the light of the pandemic, right? Things like childcare having a huge impact on people's ability to work, and the trickle down or the ripple effect, right? Of if we close schools, then the kids are home, then the parents can't work, then they're going to lose money, right? Just like we discovered that with the pandemic, we're discovering, people's access to health care and health resources is not the same across the board. That's a problem for all of society when there's a pandemic. Does that make sense? So that's sort of the overall approach that sociologists take when understanding health, is that, at least most health problems, maybe not every single one, but most of the big picture problems in society related to health are social problems in and of themselves. So one of the ways that we talk about these things being socially constructed is through language. There is a process called medicalization, which is where medical professionals take control of an aspect of human life. In other words, some characteristic, some behavior, some aspect of social life starts being defined in medical terms. So one example of this is alcoholism, right? So for many, many generations, alcoholism existed, right? But we didn't have a word for it. We didn't call it that. It was individual, he drinks a lot, or she has trouble dealing, or whatever. We didn't have a name for it, right? And even if we did, it was seen as a moral failing, right? Enter the medical profession finally acknowledging, no, alcoholism is a disease, right? It follows this model of progression. Medical professionals have medicalized alcoholism. Does that make sense as a concept? So in order to change the way we think about things, oftentimes we medicalize certain conditions, right? The two forces that affect health the most are biological factors and individual decision-making, right? And so, chances are where you are in your health journey in life, what your current health status is a mix of your genetic and biological factors tied in as well to your individual decision-making, right? So, you have someone who has lung cancer may have lung cancer because they as an individual chose to smoke cigarettes. They may have lung cancer because they were biologically predisposed to it, or most likely some combination of the two, right? And so medical professionals have to be able to not only treat biological things, like a antibacterial, or antibiotic for a germ or something like that, but we also have to be able to treat individual behaviors, right? So medical professionals try to affect the behavior of their patients in order to help them make healthy decisions. And so to affect that change, right, to actually get people's behaviors to change, the medical professionals need to be able to make a case that other institutions in society, like family or religion or whatever, belong to the realm of the medical profession. So, for example, medical professionals here can mean physicians, right? Medical associations, but it could also mean pharmaceutical companies, even patients who are affected by direct ads. I don't know how many of you are old enough to remember the time before medications could be advertised on TV, prescription medications, right? Do you remember? You do vaguely? Okay, good, because it's it's on the edge of my consciousness because I didn't care as a kid, but I remember when they started advertising, and the first thing I noticed was how they had to list all the side effects, right? And I was like, oh my God, why would anyone ever take any medication? Because that's, they had to list them, but for a long time they couldn't, and so patients, were not consumers. Right, I mean, they were, but they weren't treated with ads, right? The ads went to the doctors made decisions and told them, I'm going to prescribe you this drug, right? Now, regardless of whether it's good or bad, the direction they went, now patients directly are advertised to about their medical decisions. And so, arguably, ad executives are now some kind of medical professional, right? Questions or comments about the concept of medicalization? Taking some aspect of social life and making it medicalized. So the opposite can also happen, right? There is also demedicalization, where we used to treat something like a medical issue, which we no longer do. So this is when conditions are no longer in the purview of medical institutions. Oftentimes this happens when social groups push back against the classification of a disease. So a classic example of this is the fact that homosexuality was defined as a psychiatric disorder for decades. Up until 1973, homosexuality appeared in the Diagnostic and Statistical Manual for psychiatrists. It was a mental illness. It was medicalized, right, being homosexual. In 1973, the American Psychiatric Association realized that they revised their description because it was no longer seen as an illness. It was simply an orientation, right? Just like heterosexuality or whatever. Although it wasn't actually until like 1987, I think, that they completely removed homosexuality from the DSM. But either way, this is a case where, a sexual orientation was demedicalized from being an illness to being just, a characteristic of a person.
I feel like that doesn't happen frequently. I can't really think of many other examples.
Things that have been, well, it's also hard to, because if it happened not in your lifetime, you were conditioned to not think of that thing as an illness.
That makes sense.
So, like, do you remember hysteria among women? Like,
Yeah.
I mean,
Yellow wallpaper, I remember reading that.
yes. The fact that women had some illness, right, that made them, hysterical, right?
Classic movie fan, and so a lot of classic movies are based on that hysteria.
Right. So I would argue, just emotional expression has become demedicalized to an extent compared to the, 18th or 19th century or whatever, right? So, but you're right. Maybe it's harder to think of things that have been demedicalized rather than things that have been medicalized. There's also categories of illnesses that have not been categorized as illnesses yet, but people suffer from them and they want them. So the idea that physicians do not readily acknowledge all illnesses, there have been many patient movements that have challenged what is and is not defined as a physical illness. So these are called contested illnesses. Illnesses that have a lack of consensus about the causes, symptoms, or treatment. So some classic examples are fibromyalgia is one such, and chronic fatigue syndrome is another, where they're not well-known or well-understood illnesses, and there's not a scientific consensus or medical consensus about either where they come from or how to treat them. I don't, again, not a medical doctor, so I don't know all the details, but the idea that there are illnesses we don't understand, and so some patients feel like if their illness was medicalized, then at least it would be legitimized and they could get treatment and be taken seriously, right? But while their condition is not considered an illness, maybe they're not taken seriously, right? Or something like that. So there can be, contested illnesses as well. Which just goes to show that, while medicine is science, it also is not infallible and it changes, right? And there are new illnesses discovered and old illnesses that aren't actually illnesses and things like that. Yeah, absolutely.
How far back you got pushed when the French and the Americans were arguing about where it came from?
Right. And
years because they couldn't agree on what it was.
yes. And not to mention to the racial implications with AIDS and HIV, both the, then also the homosexual aspect when it came to the U.S. and, but like tying it to Africa and saying, this is that kind of, illness that from that. So yeah, absolutely. Even when the illness itself is new or newly discovered, I should say, we fight about what it is and where it came from. COVID-19, did it come from a bat or a lab or, right? So absolutely. Good. Although I would say, hopefully we're all aware that COVID-19 is not a contested illness, it is a real illness. I feel comfortable stating that for the record. But anyway, so what's the point here for sociology, right? How do social problems affect our health? And I don't just mean like whether something's defined as an illness, although that too. But sociological studies of health and mortality, health and death or sickness, have always been central to sociology. As far back as one of the fathers of sociology, Emil Durkheim, he studied suicide as a feature of sort of modern society, that suicide rates were more common in cities than in rural areas. And what he determined from his research was that the social integration of people in cities was much lower. Like even though they were around other people, they weren't like connected to them socially. Whereas people in like rural areas, they might only have a couple neighbors, but they know them really well and they're supported, right? And so people in cities, even though they're surrounded by other humans, they felt like disconnected, and that led them to potentially, to suicide. But the point is, right, he's acknowledging, hey, social forces like integration with other humans, social forces can affect individuals' health or their lives. Another example is the one I mentioned earlier, which was a cholera epidemic in London. And there were several, and there were not just in London, but in 1854 in particular, there was an outbreak, and there was a huge disagreement between a local doctor named John Snow and the local priest who was basically in charge of medicine at the time in that neighborhood, because that's how it worked, right? And the priest thought that, the prevailing theory was something called miasma theory, which is like there's bad air, and that cholera was caused by bad air, and so everybody should just open their windows and it would get rid of it. But like I mentioned before, cholera is a waterborne illness, right? It is not affected by the air, except that I guess it dies in air because it needs to be in the water. But and so the doctor, John Snow, drew a map of the area of the outbreak, and he put little dots where all the people with cases were. And what he discovered was that they were all like centering in certain places, right? And he began to interview all the families of the cholera victims, and they all reported getting their water from the same pump in the town square. So he decided to take the handle off the pump and just to see what would happen so nobody could get water there. And all the cases dried up. Like everybody got better. Well, or they died. But I mean, like there were no new cases because people had to go to the other pumps, as far away, right? It wasn't easy to get to, but the idea was this was the infected pump, right? And so basically John Snow invented what we now call epidemiology, which is the idea that diseases, like you have to look at them from like 100 feet up in the air, right, to understand how they're moving and who's catching them and what's causing them to be caught. And so, we call John Snow as sort of the father of epidemiology. And speaking of epidemiology, what's that term? It's the term that describes the study of how diseases spread in a population. Obviously, the concept of epidemiology has become particularly salient to us all over the last 2 years. In biology and medicine, right, epidemiology, literally the study of how diseases spread, There is also social epidemiology, which just adds on the layer of social factors affecting the disease's spread and illness, right? So the study of how social position or social behaviors can affect health and illness. Questions about those definitions? So we're going to focus on the second one. I'm not an expert in either. I'm definitely not an expert in epidemiology. I do have some training in social epidemiology, but like I mentioned, Dr. Kate Darling, who teaches sociology classes for UMA, she is an expert in social epidemiology and public health. So the field of epidemiology uses three main measures to understand the spread of disease: fertility, mortality, and morbidity. So fertility, as you may guess, has to do with the number of children being born, right? So fertility is the level of childbearing. Sometimes it's per person, sometimes it's per population. I think in the U.S., it's like 1.3 births per woman in a lifetime, something like that. But I'm not sure exactly what it is, and it doesn't matter. I'm not going to test you on it.
When I was a kid, that number,
Oh yeah, how can somebody have 1.3 kid? What's a 0.3 kid?
that used to scare the crap out of me.
Yeah, oh God, is that some sort of medical?
Well, I feel like that has reduced. Like my dad had 8 siblings. It's
Right.
reduced drastically.
Right, and there was a lot of concern when the census came out, because anytime it drops, if a couple has 2 kids, right, then the population would stay the same. Like when the couple dies, they have 2 kids to replace them. So anytime it drops below 2, it implies like, oh, the population will start going down, right, as a whole. And so like the last census, everybody freaked out. Oh my God, the U.S. population is going to go down. We're not having enough babies.
That's a bad thing.
So right, well, and then on the other end of the spectrum, right, there is a cap on the top in terms of how many like animals the planet can support, right? Just like you can only have so many fish in a fish tank, right? So yeah. So anyway, so epidemiologists include the fertility rate in their studies, and I'll explain why, because they compare that to the mortality rate, which, as you might expect, is the incidence of death in a population. So the number of people who are born, the number of people who die, right? But then the third element is morbidity. And if you're like me, because I see mortal and I see morbid, and I both think they're negative things, mortality is death, morbidity is illness. Right, so morbidity rates are the study of rates of illnesses and diseases. So like the incidence rate would be like the number of new cases in a specific time period. So like, Dr. Nirav Shah, every Wednesday at 2 or whatever it is, he comes to the from the CDC and he talks about like the COVID cases. He is often talking about both incidence rates and prevalence rates. The number of new cases in a day or a week or 7-day average, whatever it is. Prevalence is the total number of cases, not the new ones. So like 5 people newly have the disease, right? But there are 30 total who do not, right? So that they use both of those terms. The other thing to distinguish here with morbidity is the difference between acute diseases and chronic diseases. So acute diseases are ones that strike suddenly and disappear quickly. They're usually fairly treatable if they don't kill you. So for example, the flu, right? The flu comes on fairly quickly, right, in the scheme of your lifetime. And it disappears pretty quickly, usually start to finish 2 weeks at most, right? Or something like tuberculosis or scarlet fever, right? It happens, you get it, you either die or you live, right? And then it's over. Yeah.
I thought back in the day, like, tuberculosis would go long term.
Well, it can last a long time if it has an end. So it's relative, how long it lasts, but yeah. And if the end isn't death, but yes. The distinction here is between a chronic illness, which is something that takes a really long time to develop in a person, right? Tuberculosis, you catch a bug and you get it. A chronic illness like heart disease or cancer, right, that slowly develops in a body, whether it's from outside forces or inside forces, genetics or smoking or whatever. Some cancers just happen because of genetics, some just happen because of exposure to, lots and lots of, it can be environmental or genetic. But the point is, chronic illnesses come on very slowly over a long period of time and often are you can treat symptoms, but oftentimes are not curable. And that's sort of the distinction between an acute and chronic illness. Either one can kill you, either one can be lived with, but it depends. So, incidentally, acute illnesses used to be the bigger killer of Americans, of people, right? Besides accidents. So taking accidents out of it, the biggest medical killer of people were acute illnesses for hundreds of years, right? But in the last 50 to 100 years, it shifted to chronic illnesses. These are the diseases that are killing people today. Because mostly we've cured or found treatments for a lot of acute illnesses. Not all of them, but many. All right, so does that distinction make sense, acute and chronic? So we have fertility, mortality, and morbidity. Those are the three variables that an epidemiologist might look at. The other thing I want to talk about before we take a break is one of the theories that has been developed to explain the connection between social problems and health. It's called the fundamental cause theory. So hopefully you see that name and you're like, oh wow, it sounds serious, right? Fundamental cause theory. It implies that there is, this theory says there is one cause, one situation, one thing that is causing almost all health issues, right? Or can be traced back to almost all health issues in the United States and around the world, but let's just take the United States. Anyone, I don't know if it's in the notes, I think it isn't, but does anyone want to guess what it is? The primary determinant of a person's health in the United States? One thing that, for no matter who you are?
Genetics.
It's not genetics.
Economic standing.
Yeah, it is your social class. It is your economic standing. I'm with you, sure, genetics, why not, right? Turns out that your socioeconomic status, your, income, wealth, occupation, all that, your economic standing is the primary determinant of a person's health, even across different places, like around the US or around the world, different time periods, for centuries. Your social class has been a bigger predictor of your health than any other factor of a person. For example, socioeconomic status affects people's exposure to stress. We know stress is a huge tie-in to straining your, stress hormones can cause your body to break down and things like that, right? Your immune system to go out of whack. Social class affects your exposure to environmental toxins. We talked about this when we talked about the environment as a social problem, where people of lower social classes are more likely to be exposed to industrial waste or to other environmental hazards, right? And of course, they can affect your health. Lack of access to high quality food. I mentioned the phrase food desert before, right? A food desert is a place, a region, a location in the US or elsewhere where there is a lack of access for the average person to access high quality, nutritious food. In many inner cities and very rural areas, you can access processed or fast foods for cheaper or more cheaply than you can access, healthy, vitamin-rich foods. It's not entirely, depending on the season in Maine, arguably in rural areas you have better access to food.
I'm going to argue that. I feel like education to access to high-quality food.
To where to find it and how to get it, and that's good.
I have a 5-month-old and people are like, you make your own baby food, but a bag of organic carrots is like $3 and I can, feed them for an extended period of time. Those little jars of
$3 each or whatever.
Yeah, they're not cheap.
Yeah.
So I think education to access high-quality food is more of a factor.
That's fair, and there are places where there's not a grocery store or a farm, and maybe not rural, but in inner cities, for example, right? No, nothing, right? Except a frozen, tons of frozen food or whatever. Not that frozen food's bad, but you know what I'm getting at. So yeah, and I agree that high quality food is easier to access when you know where or how to look. So definitely. And the last one I have is lack of access to health care as well. Obviously, the poorer you are in this country, the harder time you have accessing quality health care. So fundamental cause theory says, there's a one thing that almost all health issues can be tied back to, and it is socioeconomic status. Now, do people who believe in the fundamental class theory think that germs don't exist? Of course not. Of course they understand genetics can play a role in other things too, but that across all other things being equal, your socioeconomic status predicts your health outcomes better than any other single variable. Questions or comments about social class and health? All right. So the other thing I want to talk about before we take a break is race and health. So before I get into it, I want to mention Dorothy Roberts, who is famous in this field, a social scientist who studies race and health outcomes. She just gave a talk this week that was on Zoom that UMA folks were invited to, but she'll be coming to UMA in the spring for 2 dates. They haven't been finalized yet. I know one will be in March and probably one in April. So look in the spring for announcements about Dorothy Roberts, because it's going to be cool to meet a scholar. This is not in your notes, but so she studies the overlap between race and health, and in particular the idea that the medical community continues to insist on race and health, that there are genetic relationships between a person's race and their health, which have been disproven. So the Human Genome Project, if you remember that, basically proved that there's no gene for race, right? There's not a single gene that determines a person's race. Yet there's still a lot of interest in race-based medicine. And for example, sickle cell anemia is the famous one, right? That is an illness that is in the medical community thought to be tied to being black, right? However, Dr. Roberts and others research has shown that sickle cell anemia is tied genetically, like the allele or whatever, is tied more prevalently to places with malaria-causing mosquitoes. Guess where malaria-causing mosquitoes are very commonly found? In Africa, right? They're also very commonly found in Southeast Asia, in India, and Vietnam, Laos, Cambodia area. And sickle cell anemia rates of prevalence in Southeast Asia are the same as they are in Africa. But for whatever reason, we have decided sickle cell anemia is a black disease, right? And point to genetics to try to claim that. But she's saying, no, if you look at the genetics, it's actually tied to this, mosquito, not to people, right? And so it's a very interesting kind of phenomenon, right, of what we think about race and genetics and what we think about illness and health. So anyway, she's a cool researcher. Check her out. You can Google her. Her Wikipedia page is more or less correct. But stay tuned in the spring for that. So moving on, back to the notes and the material for today. So there are absolutely correlations between health inequality and racial inequality. For example, people of color are less likely than white residents to have health insurance. That is across the United States. And it got better with the advent of the Affordable Care Act in the mid-2010s, but it's still there's still a significant difference. So this is the rates of uninsured people. Uninsured. So we see the bottom one is yellow, right? Most whites are insured because the rate of uninsured is very low, right? 8 or 9%. Whereas, blacks and Hispanics in the United States have much higher uninsured rates, meaning there are more of them who are not insured. Partly that's because of cost, but it's also partly due to education and being able to access, sign up and enroll for programs where people don't always know how to do that. And this actually does hold outside of the United States as well. It's not just in the U.S., although these are our numbers. It is true that white citizens in many countries have higher health insurance rates, or rates of being insured, than non-whites.
Would there be a trust component to this?
I believe so, but what do you mean?
That people of color have less trust in the American healthcare industry, deservedly so?
And so choose not to engage with it in any form? Yeah, I think so. I don't know how big of an effect that is, statistically speaking, But I think, in many communities, right, who have not necessarily had the best experience with the medical community or whatever, that rushing out to get insured and go get treated when you're ill is not as much of a priority. I'd say that's very possible.
You almost need like a degree to navigate our health system. It's a little crazy.
Yeah, and not to mention, again, before the Affordable Care Act, you needed to be employed, right, or really knew how to like pay out of pocket for it. And employer-based healthcare is not always clear, and you have to enroll, and you have to know all the terminology. So I would agree completely. It's not an easy system for anybody, even those who are benefiting from it. Don't always know what they're doing.
Well, I learned to like play this game. I get a copay assistance for a prescription that I take, and my copay assistance goes towards my deductible. And my copay assistance, my prescription is $5,900 a month.
Oh my goodness.
I know. My insurance pays about $200. My copay assistance pays the rest, but $5. And so I purchased like the highest deductible
Plan.
I can.
Yeah, because thousands of dollars are.
Yeah. And it's almost like this stupid game you have to. It blows my mind.
On paper, you'd be like, no, I'm not signing up for the $5,000 deductible plan or whatever.
And
Yeah.
I'm still not paying much out of pocket. It's this copay assistance that's paying it's a silly game. I think it's ridiculous.
There.
Yeah.
One of the reasons I'm happy better.
Yeah.
Yeah,
At least it's straightforward.
I'll take my social life and medical care any day of the week.
Seriously.
Yeah. And now, there's like those apps like GoodRx or whatever to help you find cheaper. Like, why should you, the consumer, have to be the one doing that? Like, why? And I got amazing, I like Cadillac level insurance, humane system, like I'm invested, like I have good insurance. My husband's a type 1 diabetic and his insulin's covered, so we're great. But even I still have to do that to save $20 a month or whatever on a copay. Like, it's crazy. So yes, right. The knowledge and tenacity to have to to just keep going and fighting against the bureaucracy, right, is not a skill or a time suck that everybody has, right? So absolutely. Back to race again. There is also research that ties being the victim of racism, being subjected to racial discrimination, can actually explain certain kinds of health inequalities. So, for example, mothers who had experienced racial discrimination in their lifetime are more likely to have children born with what's called very low birth weight, VLBW, which is something like under 1,500 grams, I think, at time of birth, which is like under a kilo. What is that, 1,500 grams? I'm not good at conversion. We should just be metric, but that's a whole other thing. Anyway, a tiny, tiny, tiny baby, right? A pound or so, right?
2.3 pounds.
2.3?
3.3.
3.3. A 3-pound child or smaller, for reference. But anyway, right? So all other things being equal, mothers who had, all these mothers had babies. The ones that had very low birth rate turned out to be born to mothers who had experienced racial discrimination in their lifetime. So in your lifetime, being exposed to racial discrimination can have a physical effect on the children you bear. That's a huge finding, right? That this thing that happens that is mostly people being jerks can actually explain like a measurable health outcome, right? Like I mentioned before, racial residential segregation can cluster like bad environmental conditions, like environmental hazards, but also things like violence or food deserts, places where access to healthy food is hard to come by, and so the fact that we have racially segregated communities can lead to these negative health things happening more frequently in, say, Black or Hispanic neighborhoods than in white neighborhoods, even if they're the same socioeconomic status. And finally, actual discrimination, like overt discrimination, can also be a problem on people's health. Discriminatory medical practices means that racial minorities often get less adequate care than white patients. Medical professionals' personal and often unconscious biases can affect how they treat minority patients. In a study of patients at a major city's busiest hospital, so presuming there's like a good mix of different kinds of people there, Hispanic, Black, and Asian diabetes patients were less likely to receive certain key interventions like a nutritionist appointment, an endocrinologist appointment, and a insulin pump consultation or whatever. The Asian, Black, and Hispanic patients were less likely to receive those 3 interventions than the white patients were, the same hospital. Medical professionals are also more likely to underestimate the level of pain reported by their Black patients as compared to the pain of their white patients. This is also true, incidentally, for women. Women's pain is often underestimated by physicians, especially male physicians. And so obviously if you're, underestimating the kind of pain your patient is, that may lead to, affecting the quality of your diagnosis or the effectiveness of your treatment or whatever. So, and I mentioned women because there's an overlap here between race and gender as well, which is to say that Black women in particular are particularly susceptible to this kind of discriminatory medical practice. African American women are at a greater risk than white women for several medical issues, including heart disease, cervical cancer, and complications in childbirth. Even wealthy African American women are more likely to die in childbirth, much more likely to die in childbirth, than middle or lower class white women. There is a very, very high maternal mortality rate in childbirth among African American women in this country. And so what we're seeing, of course, is that gender, being a woman, and race, being African American, combine here. It's called intersectionality, right? To create a particularly risky situation for African American women and their health. Not to mention, African American women would be disproportionately exposed to discrimination. Again, being women and being Black can result in, sort of double discrimination. Questions or comments about this? Or about the relationship between race and health outcomes in the United States and elsewhere? All right. Why don't we take a break here, and when we come back, we'll talk about gender, a little bit more about gender and medicine, and then we'll talk about the healthcare system and some of the problems and how we can hopefully potentially solve them. And then we'll finish with the activity for today, and that'll be our day. So why don't we meet back here at 10 after 2, 2:10, okay? Everybody, welcome back. So in the second half of class today, we're going to talk about gender and how that relates to determinants of health. And then we'll talk about the healthcare system and some of the social problems related therein and what to do about it. So we can switch back to the computer. Just like we were talking about before the break, where fundamental cause theory says it's your social class, that's the biggest impact on your health. But then we looked at some ways that race can be an impact on your health, and now we'll talk a little bit about gender and health. Most of the differences in healthcare or in health treatment and outcomes between men and women can largely be attributed more to their gender rather than their sex, right? So it's not so much the genetic or biological differences between men and women result in different health outcomes. It's more that gender differences do. So there's this kind of classic phrase in the medical community, women get sicker, but men die quicker. Have you ever heard that one before? But it's a play on the idea, right, that women have higher rates of illness and disability, reported illness and disability, right? But men have much lower lifespans, right? And so is that because of genetics? Well, most social scientists would say no, it's because women are more likely to be taught to be caregivers, which means that they come into contact with more people who are more likely to be sick, like children and the elderly, or medical professionals, in their caregiving role, like doctors and hospitals and things like that. They're also more likely to report symptoms. That's why I said they report, higher reported rates of illness and treatment. Meanwhile, men are taught by society, to be a bit more reckless, right? So they're more likely to die from risky behaviors like use or abuse of drugs or alcohol or tobacco, driving recklessly, working in more dangerous fields, right? Those kinds of things that shorten their lifespan. So these issues are less about genetics and more about the socialization of men and women, right? Caregivers and risk takers. The good news is even if they are gender-based and not biologically based, gendered health problems do have solutions. Because the cause of these problems is rooted in a mutable, meaning a mutable set of social expectations, rather than some form of immutable, unchangeable biology. Right? If it was just simply a biological fact that men died earlier than women, and there was nothing but genetics that caused that, there'd be nothing we could do about it, right? But because there is at least some aspect of a social expectation going on here, if we wanted to, for generations, teach men not to take as many risks or not to value that kind of behavior, we could theoretically adjust that, life expectancy. Now, is it only social? No, of course not. In fact, I did read a study once that said testosterone, the actual hormone testosterone, breaks down cells faster than other hormones. And of course, men have more testosterone than women, and so their cells are dying faster than women's cells. So I'm not saying there's not also biology at play here, but it tends to be social expectations that are leading to the trends we're seeing more than genetics or biology or hormones or whatever. Fair enough? So this brings me to a general social phenomenon, not just men, not just women, not just black or white or poor or rich, and it's the idea of social isolation. So at the beginning, I mentioned Emil Durkheim was sort of the first social scientist to pay attention to health, and he studied that people who were more socially isolated were more likely to have this feeling he called anomie, and that led to suicide. But this is still true today in the sense that social isolation can affect health and illness by leaving people cut off from larger social support structures. For example, there was a big heat wave in Chicago in the 1990s. In the summer, where it was regularly getting into the hundreds and 110 degree heat indexes, right? After the heat wave, when they kind of were checking on people that hadn't been heard from in a while, the people who were most likely to die during that heat wave were people whose extended families had moved away from the city, people who were afraid of crime and so had become fairly, intentionally self-isolating, right? Or people who did not have access to social services like Meals on Wheels or just visits from other people or whatever. So the heat wave, caused heat exhaustion. That was a thing. That's a medical condition, right? But because these people were socially isolated, they didn't have anyone to call for help getting fans or AC or somewhere to go if they were hot, right? Obviously the medical condition that happened wasn't social, right? It was a heat wave caused heat stroke. But because these people were cut off from all the other kinds of supports that most people have, they succumbed to this heat wave, right?
Well, I think we're going to find the same thing with this pandemic.
I think we have started to already. In fact, yeah, absolutely. That it might not even be the COVID that actually kills someone, but their isolation leads them to succumb to some other illness or some other problem, or COVID. But that people just don't realize because they're cut off. So absolutely. There's also research that suggests that social isolation just by itself can lead directly to heart disease and decreased cognitive function. Not being around people hurts us, even if it's by choice. Long-term like hermits and things like that. If and when they are willing to submit to study afterwards, when they are no longer isolated, they also have lower, or higher rates of heart disease, lower cognitive functioning on average. Because we thrive, we are social creatures. So, questions or comments about social factors like race, class, gender, isolation, and how they affect health? All right, last but not least today then, I want to talk about the healthcare system, which of course we all know is not, it's not perfect. It's not even necessarily that great. At least not the insurance and the system itself, right? We have great men and women, individuals who dedicate their lives to helping people, but the institution of healthcare is we all know, broken in our society, and has been, right? It's not a new thing. So the institutions that we set up to deal with illness and health can also themselves cause social problems. Part of the problem in the United States is that our system is totally random. It's like a quilt made up of all these little pieces, a patchwork of coverage, right? Over the decades or hundreds of years in the United States, we've added things, taken away things, put new things in, changed how things work, and so now no two people have the exact same coverage, right? It's just a piecemeal mess. It's made up of employer-provided coverage, so most people who are employed at a full-time at a place with 10 or 15 or more employees are offered, they don't have to take, but they're offered employer-provided coverage. We also have, as you're probably familiar, Medicaid. Medicaid is the system that covers people who can't afford insurance or who are disabled. And then there's Medicare, which covers those over 65, so the elderly by this definition, the aged members of society. And even with this sort of piecemeal kind of system, more than half, or about half, of people in the U.S. go without health insurance. Definitely without full coverage, but even without any coverage. They either hope, not to need medical care, or they have to be able to pay for it out of pocket if they do have medical care. People who don't qualify for federal programs and who aren't covered by their employers have the option of buying a health insurance policy now on the market, right? That's what's part of what the Affordable Care Act did, but that can be prohibitively expensive, right? It's not just
That's hard to navigate.
And it's hard to navigate and know what you're getting and what's a PPO plan versus an HMO plan, and what's a deductible, and absolutely, right? And you need a professional to help you navigate it, let alone the average person trying to do it. So absolutely. So we know there are issues with healthcare in the United States. Arguably, sociologists say that most of these problems stem from the fact that we do not consider healthcare a right. So instead of defining healthcare as a right in this country, in our system of capitalism, healthcare is defined as a commodity. It is something to be sold to consumers. And arguably, most of the issues with the healthcare system that we are facing in the United States can be traced back to this for-profit system. Now, does that mean that a completely socialized system is without flaws? No, of course not. But the flaws we are currently experiencing are largely traced back to capitalist medical system. Yes?
So that's one thing I've never really understood. It's defined in the Constitution as a right. Why are we not considering?
Do you mean like because life, liberty, and the pursuit of happiness? Because it's not in the Bill of Rights. It's not like its own
Gotcha.
right? So we would need an amendment declaring it a right.
So it doesn't
Because
say
happiness
it the right
isn't in the Bill of Rights either, right? And
So it doesn't say it the right
it
way.
doesn't say it the right way, yes. There are a few things that other, particularly European countries, but other countries declare as things. Education is sometimes declared as a right, which is not in the U.S. Healthcare, we all saw at the last Maine election, right? Food was, one of the referendums was to declare food, access to food, a human right. So there are a lot of things that are not fully declared rights in this country, either federally or statewide. No, health is not one of them. And so, so the fact that we see it as a commodity, as a country anyway, and the fact that I mentioned before, which is that we've shifted away from preventive medicine to a focus on more like curative, or sometimes it's called crisis medicine, like where you only go to the doctor when you're sick, right? Rather than the old kind of model, which is you go all the time to make sure you don't get sick. Now people just go when they already are sick.
And it's far more costly.
It's
Does it make sense?
it's far more costly, but it's kind of like you hope you're going to game the system until you can't anymore, right? And so and sometimes colloquially we call it the sick care system instead of the health care system. It's the same idea with the vaccine for COVID-19 versus the pill for COVID-19 that was recently announced, right? One of them greatly reduces, allows you to prevent getting your chances of getting the illness. The other, you have to wait till you get it and then treat it, right? It's much, much better to not get the thing to begin with. And it's less costly to do it that way, right, on the system. But, of course, that's not the way we are trained, right? You get sick and then you treat it.
Because I would argue there is not much of a focus on the curative model.
Fair. I mean, the term curative means like treatment to stop the disease, but I guess you're saying people are like motivated to
There's no money
in curing, right?
treating this.
Fair enough. The medical terminology calls it curative medicine, but I hear what you're saying, and arguably, certainly on the pharmaceutical side, especially, right? There's more money to be making in like long-term chronic treatment, but not in curing. Same with like diabetes. Much rather have people pay for insulin forever rather than actually try to create an artificial pancreas or whatever.
Or like homeopathic medication, people consider that like witchcraft.
Yeah, right. No, that won't work.
I mean, I agree that there are people in the field trying and focusing on cures, but when it comes to actual patient treatment,
How's the system laid out?
yeah, that is never really seen to be the focus.
Right. Treatment, but not curation or cure.
I mean, like going back to AIDS.
Mm-hmm. Right.
We have plenty of drugs
The antiretrovirals and things are treatments, but not.
plenty of drugs to treat it, but why did we stop focusing on curing?
Yeah, fair enough.
Because we have all these drugs to treat.
Right. And I mean, cancer is a similar thing. Now, there are 4,000 different kinds of cancers and where they come from, and maybe you can cure one or two, but not all. I know that's a bigger mess, but like, same idea, right? When I was a kid, people would be like, I want to grow up and cure cancer. That was like, you'd be a hero, but you wouldn't make any money. Fair enough, right? So money is a huge issue in healthcare, both the cost and the motivation, behind it. Here's the high cost of medical procedures themselves. Despite all of this cost, so part of it is because, people overutilize services or like unnecessary services, where a new hospital will be like, oh, we've got an MRI machine, and everybody wants to get an MRI, right? Because they think it's going to solve all their problems, right? And so that costs tons of money, and so the hospital now has to charge more for other things because all people just want their MRI,
Yeah.
when it's unnecessary.
If you're charging more than $1 for ibuprofen, you need to be in jail. Sorry.
Right. The same with insulin, man, but yes. And because we have this patchwork system where nobody talks to each other and it's not all comprehensive, right? These guys could be charging this and they can charge that and nobody will know, and it's not, right? It's just, We're spending more on administrative costs. That's the overhead. That's what we're paying for, all these costs, right? It isn't the chemicals that go into the Tylenol, right? Or even the chips and the electronic equipment that goes into the MRI machine, right? It's the administrative costs that we're paying for. And what do we get for that high cost? Oh, lower life expectancy than any other country that charges even close to the same amounts for healthcare, and less health while we're alive, right? Fewer, health markers and outcomes. And as I mentioned, we have, very poor universal health insurance, right? We don't have universal health insurance at all. But the insurance coverage we do have is incomplete. Like dental and vision is another thing where dental health is directly tied to physical health, and in fact many bad things in your physical health have warning signs in your dental health that can be seen in advance, right? But dental health is rarely a guaranteed coverage, as part of the system. Even in my Cadillac insurance, it's extra. I mean, it's not that much more, but it's an add-on I have to selectively choose every year.
Well, and as an employer, in looking at different dental plans, there were some dental plans that would basically only cover 2 cleanings for the year, for the first year.
Yeah.
Which I found bizarre.
Yeah.
If you had to get a tooth extracted or anything like that.
Nothing.
No, it wouldn't cover a thing for the first year.
Yeah.
It kind of blew my mind. I'm like, that's bizarre. At Aflac. And I decided not to go with them.
Yeah.
My employees deserve to be able to have some form of beyond a cleaning.
Yeah, and again, it'll save money down the road, but it doesn't feel that way at the outset, right? So
My doctor has to get very creative glasses because I'm not 100% stable.
Uh-huh.
The VA doesn't cover my eyes.
Okay.
But because I have diabetes, that's covered.
Because of the ocular
So she
issues.
sends me in for diabetic eye exams. The people at the eye clinic know what's up.
Yeah.
Oh no, it's changed a little bit. We need to give them new glasses now.
Gotcha. Yeah. 0.25 change
Yeah,
or whatever
so
to
my eyes aren't covered, but my diabetes is, so I get the treatment for my
through that.
It's also stupid.
Right.
It's incredibly stupid.
Yeah. And the last one is the one that we probably are all familiar with, which is the impact on the financial lives of anyone who has a health emergency. In this country, there was just a study done maybe 2 weeks ago that asked people if you were hit with an unexpected $400 medical bill, would that be a problem for you? More than half of the country, right? More than 2/3 of the country said, this would be a significant problem for me, $400 unexpected medical bill, right? And for half of the people in the study, it would be a ruinous financial effect. Like they could lose their home or not feed their family because of that, right? That's how close we live to, chaos, to financial ruin. And medical debt is the #1 cause of personal bankruptcy filing in the United States. Instead of the ambulance, yes. People refusing ambulances when they need them because of the cost, or taking Uber, or all sorts of things to avoid medical debt. And that's when they're aware of it on top of it. If you're unconscious, you don't get to say, no ambulance, please, right? And then you're hit with this bill, and yeah. So to compare, we know the outcomes are not great, right? That our healthcare system isn't working. So, what does work? Well, so here's a graph of the countries that pay the top 10 amounts for medical care every year, right? The total health expenditures per capita for the top 10 countries. And this was in 2016, right? So you can see the United States spends more than any other country in the world, and the other 8 or 9 are European countries, but the U.S. spends more than any other country in the world on healthcare.
Is this per person?
Per capita is per person in a year. So about $9,800, almost $10,000 per person every year is spent in healthcare in the United States, right? And this is about 8,076, 66, right? It goes lower.
And that is consumer money, not government.
No.
That is how much money the government spends per?
Yes.
Okay.
Yes, it is government spent. Correct, right, government health expenditures. So how much the U.S. spends, covering or not covering, you know, their people, right? So again, we do spend more than any other country, but you can see lots of other countries spend a fair amount, right, a lot. So let's compare outcomes then, right? Here is the same countries, plus a few more. This is the top 20 countries in the world based on life expectancy. And I'll save you the time, the United States isn't even on the list, right? Our life expectancy is about 79, so we're about here. Like our bar would come out to here, but we are not in the top 20 countries around the world for life expectancy. As you can see, Japan and Singapore, people live well into their 80s. On average, most of these blue-greens are European countries. Those are most of the ones from the list on the previous slide, right? You know, I'm not going to go one for all of them, but so as you can see, though the U.S. spends more than any European country on their healthcare, every European country has higher life expectancy than we do. And for the exact ones that were on, this list.
Switzerland was like number 3 on that list, and they're like 1,000.
Yeah, they spend a lot of money. They spend a lot of money, but they sure live a long time they get a good ROI, right? A good return on their investment.
Like it's like $2,000 less than the United States does.
Yeah, so I went to a website I'm going to show you in a few minutes, right? And I put in all 10 of these countries, right, for life expectancy just to compare, right? So here they all are, all laid out, and we are this one. Right? Even of just those 10, the 10 countries that spend the most money every year on health care, right? Every single other one has a higher life expectancy than we do. And what the actual numbers is here just to show you what they were, but it's, you know, it's only like a 2 or 3 year difference ultimately. We're at 79 and others are at like 81, 82, 83, right? But still.
That's still pretty stark.
It is, and it is a statistically significant, you know, difference. So we're spending the money, but we're not seeing the results like these other countries are. There are a lot of potential reasons why this might be, but the most likely explanation in our situation in the United States is what we call the corporatization of healthcare, which is to say the privatization of healthcare. Hospitals used to be nonprofit organizations. They no longer are. Even the religious-based ones are usually proprietary now, meaning they are owned by investors rather than being, you know, a 501c3 nonprofit. Anytime you have investors, the organization is no longer, their mission is no longer whatever it was. It has to be profit for the investors. That's what the mission of anything investor-owned is, you know, in economics and in capitalism. And so hospitals are actually now referred to in the industry as profit centers, not as institutions, not as hospitals. They're profit centers. And patients are not referred to as patients, they are referred to as revenue bodies, which is extra creepy with the word body there. Like,
that's disgusting.
It's matrixy.
Yeah, that's very disgusting.
Mm-hmm.
I'm actually going to stop it right here on the healthcare system because I think she already hit all the good points I wanted to get to. But thank you for listening.